Greetings, everybody. I believe it's mostly good afternoon, good evening, and maybe good morning to some of us. We are so glad to have you in this webinar. My name is Anne Waithaka. I'm a Senior Communications Officer at the African Population and Health Research Center. This is the second webinar in a series on strengthening regional AMR research systems in Africa. And we hope you joined the last one, but I'll share the link in case you did not. We will be hearing from an AMR expert from Burkina Faso, Daniel Valia, and we'll also hear from my colleague, Alipio Nyandu, who's a project coordinator at APHRC. And before Daniel presents, Alipio will be able to give us a background on why we're here and what you're trying to do for AMR and AMR research in Africa. Dr. Daniel, who's our speaker for today, is a researcher at the Clinical Research Unit of Nanori in Burkina Faso, and this is where he's been working since 2014. And before his presentation, he'll be able to give us more information about his work, what he's been able to do, and his experience in implementing the Kabu Aiko. He will tell us more about what that means, which is funded or was funded under the JPI AMR initiative. So in the interest of time, I will welcome Alipio. And as I do that, participants, feel free to check in the chat. Let us know where you're tuning in from. And yeah, Alipio, welcome.
You're muted, Alipio. You are muted.
Oh, I was not. At some point, I lost Anne. I thought she. Okay. Thanks a lot. Yeah. Let me. Give me 1 minute. I can be able to share my screen. Can you see my screen?
Not yet.
Oh, not yet. Is Tina?
It's coming on, but not yet. Yes, now it's on. Please proceed.
Oh, okay. So you can hear me. Okay.
Yes.
So yes. Thank you again, everyone. It's great to be with you today, and it's also a great pleasure to be able to continue. Also in line of what will come the next few months to come. So we are here talking about the regional systems approach to antimicrobial resistance research strengthening in Africa, because as you know, current estimates show that Africa has got the highest and growing AMR burden, and we know we have also a number of initiatives that are doing research on antimicrobial resistance in Africa, but these projects all these efforts are tend to be mostly vertical projects that are funded, and once they are funded and they are gone, the efforts are nowhere to be seen. And we think that from those projects that are done vertically, or if I would say that are done by in some areas of Africa, so we should be able to put all their evidences together and be able to connect and make sure that their evidence is used to strengthen our systems. And we are here under this what we call JPMI, which is Joint Programming Initiative for Antimicrobial Resistance Projects. This is a program that was until last year was funded by the European Union, and this days it has transitioned. It's now called One Health. Maybe Daniel will be able to talk more about this deeply. So yeah, but that's why we're convening here, because today, because this program has been funding some of research in Africa, and since 2021, the African Population Health Research Center, in collaboration with research partner institutions across 13 African countries, we have been running research projects on antimicrobial resistance in Africa. So some of these projects have concluded their implementation. We are now trying to see how their evidence can be shared with you, shared with people for appropriate action, or to see how their evidence can be used to generate more actions to prevent antimicrobial resistance. Yeah, that's how we do. That's how I would summarize our thinking of how we should be able to work together to strengthen regional systems approach for antimicrobial research in Africa. Yes, as I have said,
Alipio, are you there?
Across most African countries in Africa is not yet that advanced to be able
Alipio?
to yes.
It seems you're having a bit of internet issues. Maybe you can switch off your video.
Okay.
To optimize. Thank you.
Yeah, thank you. Yes. Do you hear me very well now?
Yes.
Okay, thanks a lot. And so, as I was saying, that in most countries across Africa, so the lab capacity is still limited, and it's not able to track the progression of antimicrobial resistance, and it constitutes a threat to the progress of anything or efforts that we'll be able to do to curb the spread or the increase of antimicrobial resistance across Africa. Yes, as I said, also the reason why we have some such initiatives across Africa that are being carried out to see the prevalence or the spread of antimicrobial resistance in Africa. But most of these projects, they are externally funded, mostly funded by initiatives from Europe or the West countries, and there are very limited projects that are funded by government across Africa. And all these projects being being based on research grants, they tend to be for a short time, and their extension is not assured if we look at how they're just focusing on achieving their objectives, and sometimes they make publications and it stops from there. So our thinking with this initiative is that we continue to discuss about the findings from this project, and we hope that it can inspire more research initiatives or other policy actions that are needed to continue to strengthen efforts to combat antimicrobial resistance across Africa. And again, as I said at the beginning, we are meeting here today in the framework of this JPMI Fund Management Initiative that was established between the African Population, Africa IPHRC, and the Swedish International Fund Development Agency, SIDA. So in 2021, we partnered for this implementation of their JPMI funded project across 13 African countries. And we have been able to run 22 research projects across 13 African countries. These projects have already produced enough research outputs, including 19 publications, but I think these days they are even more. And one of the implication is now that we need to have this project, whatever this project have generated as evidence, we need to connect them to be able to inform further actions across Africa. And that's why we are, as I said, I'm still mentioning it, we are convening here today to be able to share from experiences from different projects. And as I mentioned, we had the first webinar in November last year, and today we're having the second one to hear from experience from Burkina Faso. The project that Dr. Daniel is going to present about was carried out jointly in Burkina Faso and the DRC. He will be able to share about these experiences from both countries. Yeah. So our aim is that we can be able to have the evidence generated by this project across these countries in blue. This map is where our projects have worked across these countries in Africa, in Mali, Madagascar, I think Mozambique, Malawi, Zambia, Tanzania, DRC, Uganda, and Kenya, and Gambia, Mali, and I think also in Senegal, Burkina Faso. So we hope that we can be able to, as we continue to work together within this framework of the primary project, we can be able to grow efforts to collaborate and have a regional platform where we can still keep discussing about efforts to fight against antimicrobial resistance. Yeah, this is also aligned with our vision as EPHRC, because our vision is to transform lives through research across Africa. And we think that once research is done, it should generate evidence, and when this evidence is generated, it should be used to transform people's life in the different ways, including to use the evidence from the research to make a decision that directly impacts the people's life, and to also make sure that the research that is done is not just kept in the shelves, but it is also used by other people for more research, to generate more research questions, and if more research is done, we also expect that more lives will continue to be transformed. So yeah, that's our vision about it. So yeah, as I said, the goal is strengthen of this initiative is to be able to strengthen country systems and cross-country partnership for IMR research and surveillance response across Africa. We hope that these webinars will be able to facilitate knowledge exchange and build or strengthen regional cross-country collaborations. And also from the discussion that we'll be having through these webinars, we'll be able to identify other research gaps that people should explore and start implementing or look for solutions. Yeah. Based on the project that we have been carrying out since 2021, so our webinars are focusing on about five thematic areas. The first webinar discussed about environmental AMR monitoring. Today we are discussing about behavioral strategies for stewardship, and we will be able to cover all these thematic areas in the next few months. So I think I just was a brief introduction so that you can know what the reason why we are here today. I think that it kind of somehow explains why we are meeting here today, and I turn the floor to Anne to coordinate us for the next steps.
Thank you, Alipio. Thank you. In case of any questions, participants, feel free to use the chat feature, although the Q&A feature might be better, and myself and my colleagues will answer the questions as we proceed. Otherwise, please continue introducing and telling us where you're coming from and your institution in the chat. Daniel, welcome.
Thank you very much, Han. So my name is Dr. Valia Daniel. So I've been working at the Clinical Research Unit of Nanuro in Burkina Faso since 2014, as Anne said before, where I have balanced my background as a medical doctor with advanced research in public health and medical sciences. So my research activity are primarily focused on understanding the drivers of AMR transmission beyond hospital setting, with a specific emphasis on primary healthcare facilities and communities. So integrating expertise in infectious diseases, epidemiology, microbiology, and also molecular biology techniques. The goal of my work was to generate evidence for targeted, affordable infection prevention and control strategies that are specifically tailored to resource-limited environments as Burkina Faso and most of low-income sub-Saharan African countries. So I have recently been appointed as a lecturer researcher at a newly established Faculty of Medicine of Yembila Abdoulaye Togoyini University in Eastern Burkina Faso, where I am responsible for coordinating and teaching epidemiology to medical students. And this appointment also includes an affiliation with the National Institute of Public Health of Burkina Faso. So this represents a valuable opportunity for me, on the one hand, to transfer knowledge on evidence-based prescription to future physicians, and on the other, to translate research finding into practice. Besides that, my work led me to be appointed as a member of the technical advisory group on AWA through the WHO. So now we can go deep on the presentation if I'm allowed by Han to share my screen.
Yes, please proceed.
Okay. Let me. Oh, can you see my screen?
Yes, yes, we can.
Okay.
And the
I
slides are
think,
moving, okay, okay.
yeah. So I don't know why.
No, the slides are moving, okay. I think it's okay to proceed.
Okay.
Yeah.
Moving, okay. So what we'll be sharing with you is our work from rural setting from Burkina Faso. So the title is High Prevalence of Antimicrobial Resistance in Rural Burkina Faso. We will, through this presentation, we're going to assess the risk factors as well as the informed antimicrobial stewardship intervention. So you all know the burden of AMR. So from attributable death and where this burden is the highest. As you can see, West African countries are sharing the highest burden with Asian countries. So, and the most pathogen included leading this highest burden are Streptococcus pneumonia, Mycobacterium tuberculosis, Klebsiella pneumonia, E. coli. So, Klebsiella pneumonia and E. coli are among the leading causes of this highest burden around the world, and mostly in Western Sub-Saharan Africa, as you can see here on these pictures. So let me show you here the risk factor and transmission pathway we are facing generally in most low in middle income countries. So from antibiotic incorrect use, as you can see here, from antibiotic incorrect use, so human can bear in is good resistant bacteria as well as animal as well if antibiotic is overused. So this may lead to resistant bacteria to be in the goods. And then from the animal and human can also reject this resistant bacteria from the feces in the environment. And then this human can reinfect themselves in the community through water, soil, and food by eating from this environment, polluted environment. Also, these men bearing resistant bacteria can also share directly is resistant bacteria to the community is belong. So this is how generally resistant bacteria are being transmitted in our settings. Also, the human bearing this resistant bacteria can also get to the hospital and directly share these resistant bacteria with other patients, or practices in hospital regarding higher antimicrobial use can also lead to patient living at home with resistant bacteria in his goods, and then continue this transmission. And then to fight again AMR in such a setting should be, you can see that this should be a bit complex, not only targeted antibiotic use alone, but all factor underlying these facts. To fight against this AMR, so the WHO Assembly in May 2015 adopted a global action plan with 5 key objectives. So I think everyone should know this key. I will not read it, but there is a 5 key adopted by the WHO Global Action Plan. And then also antibiotics has been classed in 3 main groups: access, which would be widely available. This group of antibiotics have low resistance potential, so they should be widely available in the healthcare facilities. So we have also the watch group. This the critical important antibiotic for human are among this group, and they have high resistance potential. So we need to be careful while using them for patient care. Also, we have the reserve group antibiotics. So this group should be the last resort antibiotics. So only use them when all available other medicine fail. So this has the name goes reserve antibiotic. So they should be used with very big prudently. Okay, to follow the global antibiotic plan, so most of African countries also adopted the national action plan, but fully implemented this national action plan is very problematic because of lack of political commitment. Is AMR really relevant for politics, for all those who have the finance, and then how should we handle this to get things move forward? So this is lacking in our settings. Also, as I said, be inadequate funding, also lack of human resources and weak medicine regulatory systems. Also, poor coordination. You see that to tackle AMR in our setting should be tackled in a One Health way. So how these different branches are coordinating is very poor in our settings. So the majority of this work have been conducted in Burkina Faso. So let me give you a brief overview of our country, Burkina Faso. So Burkina Faso, as you can see here, is in West Africa. It's a West African country. So population more than 20 million, and so mostly living in rural area. As you can see here, almost 75% are living in rural areas, and under 15 here represent merely half of the population, and life expectancy at birth is about 60 years. How the health system is organized in Burkina Faso. So it is organized in the pyramidal way, as you can see in this slide. And then we have a peripheral level, the intermediate level, and then the central level. And this follow the reference way, how patients will be referred from this level to this one, and then from this one to this one. So this represents the primary healthcare facility. So the CMA here, you can see CMA is Centre Médical avec Antenne Chirurgicale. It is in French. It's a district hospital. and patients from the primary healthcare facilities, CM and CSPS, should be referred them when they cannot be cured at this two first level. So we need to precise that at the CSPS level, we do not have medical doctors. All consultation and prescription are nurse-led. So only nurses are there and giving consultation and prescribing even antibiotics. At CM, we have generally one medical doctor, but all the consultation, almost all the consultation and prescription are being led by nurse also. So at this level, we don't have laboratory. We do not have laboratory. And to manage febrile illnesses, we only have malaria RDT to support the diagnostic. So when malaria RDT is positive, then it's malaria, and then nurses usually give a malaria drug. But when it's negative, then they start reflecting on how to behave in front of the patient with fever and maybe other symptoms. Is it a bacterial disease infection with a bacteria or other pathogen? They cannot know that because they have nothing to support this testing. So sometimes they end up prescribing inappropriately antibiotics. And we need to also say that in all this level of care, healthcare is covered for less than 5-year-old children and for pregnant women. But for all others, more than 5 years, so healthcare is out-of-pocket paid. So, and this is not covered by an insurance, for example. So it's out-of-pocket paid by the patient himself or his family. And near to this well-shaped health system organization, we also have pharmacies, community pharmacies generally, who sometimes also can sell antibiotics without any prescription from the healthcare system, from healthcare facility. Also, we have also informal medicine outlet close to this formal pharmacies and the healthcare facilities. So also there, you can find antibiotics and buy them at your convenience as well. And also regarding the water sanitation and hygiene condition, you can see in this photo. This is a real photo taken from our research area, and you can see that the water and water sanitation condition is very poor as well. All this can influence what we'll see next in our regarding the extent of the resistance we have in Nanuru and in most of African countries. So what were our hypotheses and research rationale? So we found in Nanuru District Hospital that during the 10 past year up until now, we are patient admitted from the Nanuru District Hospital and over all the other hospitals of the country. We found that resistant bacteria, mainly ESBL, E. coli, and Klebsiella pneumoniae, were increasingly isolated from this admitted patient sample. And then we start reflecting, why does this is happening? Maybe we have a huge reservoir in the community because all these sample we had were from community acquired because there have been sample right away, the admission in the hospital. So likely a community acquired because they did not spend a time in hospital yet. So that lead us reflection on maybe there is a huge reservoir in the community. As you may know, people bearing resistant bacteria in the goods are more likely to get infected with resistant bacteria than those not bearing them in the goods. So we try to see if this reservoir is very high and is not flooding this infection, community-acquired infection we are seeing in our hospitals. And then if this reservoir is high, what may be underlying it. Antibiotics incorrect use, for sure. Maybe supported by knowledge on antibiotic. Maybe knowledge is not good either from the from healthcare providers or from community members as well. What are community seeking healthcare seeking pattern that may be also flooding reservoir. Also provider specific dispensing, as you see in the previous slides. We have a lot of provider from healthcare facility, healthcare workers in healthcare centers. We also have self-medication from formal pharmacies as well as informal drug vendors as well. So all these can be fueling this reservoir. Also, the community member behavior with the environment may be facilitating this AMR spread in our community, all this being supported by the socioeconomic status. So the objective was then to determine the extent of this recent bacteria in the community, and then also to investigate the molecular characteristic, and then to investigate how community antibiotic use can be fueling that. And then at the latest point, to inform targeted and context-specific AMS, antimicrobial stewardship intervention to curb down all this. And so this is, I will take you through all this step-wise presentation, and then you will see how we perform it in Nanoro, our rural setting in Burkina Faso, Nanoro. So for this first paper published in Clinical and Microbiology Infection, so we measure the extent of the recent bacteria, mainly ESBL, E. coli, and Klebsiella pneumoniae in community members. And through this research, we also investigate the water sanitation and hygiene condition. And as you can see, more than 21% of this community were drinking water from unprotected water source, as you can see here. And then also more than 75% were using open defecation instead of using latrine, for example. And more than 90% declare not washing, for example, their hand with soap before eating. And we found a very huge prevalence of resistant bacteria, mainly ESBL, E. coli, and Klebsiella pneumoniae, more than 60%. And this was very associated with low socioeconomic status. Lowest the socioeconomic status is, highest is the colonization with this resistant bacteria. Also, those not washing hand with soap were more likely to bear resistant bacteria in the gut compared to those who were washing their hand with soap before eating. Also, rainy season we were associated with higher colonization rate in the community. And then when we check antibiotic susceptibility testing of this bacteria isolated. So before I get down to that, I would like to state a bit the figure. So the horizontal bar is to see the prevalence of each antibiotic class. For example, if you see penicillin horizontally, so you show the recent rate of penicillin, for example. And then here, for example, if you take quinolone, so also here this proportion, see the rate of recent regarding this antibiotic class. And the vertical bar is showing the multi-drug resistant pattern, and the dot is showing for each class antibiotic associated in this MDA presentation. So we found that you see all these bacteria isolated from E. coli, they're almost multi-drug resistant. They're almost showing multi-drug resistant pattern. And this so compromising, for example, other option. For example, if you take, for example, fluoroquinolone here, we have almost 70% of resistance in association to the other. So this is compromising the oral, the other treatment option. For example, you may know that E. coli are the most frequent agent for urinary tract infection, for example. And then fluoroquinolone are the main treatment of these diseases. So if someone in this community is going through a urinary tract infection by an ESBL E. coli, you may not be able to treat it with, for example, a fluoroquinolone or cotrimoxazole and nitrofurantoin. And then this case will be surely complicated and be referred in a higher level of care, for example. I'm not sure if they will be able to afford the medicine has carbapenem as the drug which should be used to treat this, and this drug are not affordable for our population. As I told you, it's a out of healthcare out of pocket paid. So most of people cannot afford treatment with a carbapenem, you see. And we also find carbapenem resistant also bacteria here in the Escherichia coli we isolated during our investigation. Also, this was quite the same with Klebsiella pneumoniae isolate. They behave the same with the E. coli isolate as well. And when we checked for the gene, we found that CTX M15 was the most ESBL gene detected. And this gene was also co-detected with other ESBL gene as well. And we found a carbapenemase NDM5. We found one NDM5, even though known carbapenemase has been reported in our research area, but we found one all the same. Also, a lot of plasmid-mediated quinolone were frequently detected alongside with this beta-lactamase gene. So this to explain what we saw before regarding the resistance, fluoroquinolone resistance. Also quite the same with the Klebsiella pneumoniae isolated. Here we have a lot of SHV gene as well, and also a lot of plasmid-mediated quinolone resistance. So it looked like almost all the beta-lactamase gene were associated with, has been found along with fluoroquinolone resistant gene. So this may be explaining what we saw before in the previous slides. Okay, so to go deep on that, what may be explaining what we found, the vast, very large resistance rates we observed? What may be explaining that? So to go deep on it, we try to check antibiotic use. So what we did in this research is that, based in the non-district hospital, we try to see what is happening in the community before people get into the hospital, before they are admitted into hospital. So we make for all people attending the non-district hospital, we have asked regarding the antibiotic use before the weeks or 2 weeks before they attend the district hospital. And then we found that pre-hospital antibiotic use were almost 40%. So 40% of the patient entering the non-district hospital were using antibiotic before. So and then for this patient, we saw that those who has been referred from nurses in PSC, in primary healthcare facilities, 54% of them were used antibiotics. And also, what was very important for us is also for self-referred. Self-referred are those who come directly from home, from the community, without going first to a primary healthcare facility. So almost 30% of them were using antibiotic. And our question was, where did they found these antibiotics? And in whole hospital antibiotic, what group antibiotic were more than 37%. And we see this antibiotic should be presently used because of high resistance risk, but almost 40% were of all the antibiotic use were from this group. And if you see for those, 42% were prescribed by nurses in PSC, but almost 30% were not prescribed. So where does patient get these high resistance potential antibiotics in the community? And this take us to the next research to see where people look for healthcare when they are sick. So, and we found that in this research that the main place was still the healthcare facility. So more than 60%. But if you see here, this is also huge. So more than 33% are looking for healthcare outside healthcare facility when they are sick. And this healthcare outside healthcare facility are mainly in formal pharmacies and in informal medicine drug outlets. So you see, informal outlets is more than 48%, and informal pharmacy and leftover antibiotics were 43%. So almost balanced between the two. When we ask for the reason for seeking for healthcare outside healthcare facility, the first reason was financial limitation. As I told you before, healthcare costs are out of pocket paid, and then people sometimes do not have a lot of money to pay for consultation, because in healthcare facility you have to pay for consultation, and then after consultation they will do a prescription, and for the drug you also need to pay. And for that, this is quite heavy for people in the rural setting like Nanoro. So sometimes they end up self-medicating directly, either from formal pharmacies or informal medicine outlets. For formal pharmacy, they do not have to pay for the consultation. They only pay the drug, and then they start taking it at home. For informal medicine, they only propose a more suitable proposition, because for at the level you can maybe only buy one antibiotic. For example, if the informal vendors say that, okay, you need maybe to take ciprofloxacin to cure your disease, and then if the treatment costs, for example, $10 or $20, and then you cannot afford it, it can only sell you one tablet which costs maybe just $2, and then you buy it and you take it, you go back home. If 2 days later you feel yourself, you don't feel yourself good, and then you go back again to buy maybe 1 or 2 tablets, and so on. So you see how it's going in the outlet. What they also point out was a difficult geographical access. When, for example, it rain, sometimes it's not about distance, for example, it's about accessibility. For example, if there is a bridge and after rain, the bridge is flooded, for example, they cannot have access. And then they turn on the informal drug vendors, which are with them, who are with them in the community. Also, they tell that sometimes in healthcare facility, they have to wait long. If they go for a consultation, they have to wait long. And sometimes healthcare professionals have also a professional attitude toward them, an empathic attitude. So they prefer go self-medicating either at formal pharmacies or informal vendors outlets. We also checked during this research. We also checked knowledge, antibiotic knowledge, and from the community, we found that they perceive antibiotics similar as painkiller, so they cannot make different whether an antibiotic, a medicine is an antibiotic or a painkiller. No, they take it because it treats their diseases. They only know that, and then painkiller or antibiotic, they do not know that. When you check from the informal vendors, they have also a very vague knowledge. They're only based on the pictures on the packaging. For example, if someone in the packaging is hand is in his head, then this medicine is to treat headache, for example, and it's how they behave on prescribing medicine, and they cannot tell you whether an antibiotic, a medicine is an antibiotic or not. For formal pharmacies vendors, as they said that antibiotic can be used to kill microbe and treat infectious disease. You can see that this is also very vague as knowledge. And for healthcare professional, The answer includes, but not only, the fact that antibiotic had the ability to fight against bacteria, but this was not the only answer they gave. So also knowledge was also very vague at the level. And always in this research, if you see who was looking for healthcare outside healthcare facility, we see that for those less than 5 years, where healthcare costs are covered by the government, so less of them are looking for healthcare outside healthcare facility. But for those more than five and above, who healthcare costs are not covered. So a lot of them are looking for healthcare outside healthcare facilities. So we have supporting the finding from the social science research we have presented in the previous slide. Also, we found that higher is the socioeconomic level, then lower is the research of healthcare outside healthcare facility. All these supporting our previous funding in the previous slides. We then try to explore the dispensing practice regarding the different providers in the community, from healthcare facilities, from informal drug vendors, and then from formal pharmacies vendor. We try to check how they are dispensing antibiotics. And we found that, you see that from patient, so this was a visit-exit interview from patient exiting each type of healthcare provider. Then we surveyed them at the exit of drug shop, and then to see what will take them to the hospital or to this healthcare provider, what was the symptom presented, and also what was the drug prescribed. And then we do that for healthcare facility, for formal pharmacies, as well for informal drug vendor as well. And for healthcare facility, more than 55% were prescribed antibiotics. And for formal pharmacies and informal drug vendors, you can see that it's quite balanced. Antibiotic dispensing were quite balanced between these two types of providers. And then when we check regarding diagnostics which lead to antibiotic dispensing, you can see that even in healthcare facilities, in primary healthcare facility, you can see here malaria, almost 34% of malaria cases lead to antibiotic prescription. And before I go to the other, I need to precise that, for example, malaria here is only malaria, because when someone, in our research, when someone have malaria and other diseases that may lead to antibiotic prescription, then we put that second diagnostic instead of malaria. For example, it is malaria and respiratory tract infection. Then we put the respiratory tract infection diseases, because this one may be leading to antibiotic prescription instead of malaria. So if you put here malaria, it's malaria alone without any other symptom associated. And then you can find that even in primary healthcare facility, almost 34% of these patients are prescribed antibiotics. Also for rhinopharyngitis, for which antibiotic is not necessary, there have been prescribed antibiotic even in healthcare facilities, bronchitis as well. Also for those with differentiated fever, they have fever, but malaria addity is negative. And so nurses, they do not know what is going on. So they generally give antibiotic to this patient. Also for non-bloody diarrhea, gastroenteritis here, with non-bloody diarrhea, they're also eager to prescribe antibiotics. Also for simple wound, not with infection, but simple wound, they also directly prescribe antibiotics. When we go to formal pharmacies, it's quite the same. You can see also for pharyngitis, for bronchitis, maybe at slightly different proportion, but they also give antibiotics as well. Also for gastroenteritis, not with non-bloody diarrhea. Also for wound, generally they directly give also antibiotics here as well. For informal vendors, you can see that for pharyngitis, for bronchitis also, also for gastroenteritis. So it looked like they learn from the healthcare facility what have been what is going in the healthcare facilities, and it seemed that they learn from that, and then they try to follow as well. And we see for all these symptoms previously said I presented, also for all these symptoms they also give antibiotic as well. And when we check the percentage of the watch group antibiotic, the antibiotic with higher resistance potential, we found that for outpatient here, and this is for the patient, because when we went for into primary healthcare facilities, we also check antibiotic for those who were in observation, because in primary healthcare facility they do not hospitalize, they only put patient in observation for 48 hours maximum. And then if the healthcare condition does not improve, they have to refer it to a higher level. So we also check here. But here you see it's for outpatient, and you can see that the percentage of watch antibiotic is also very important. You can see here malaria alone, and then watch antibiotic are given for undifferentiated fever, stomach ache, and you can see for very huge watch antibiotic has been dispensed. And also for self-medicated in formal pharmacies. So pharmacy worker also give watch antibiotic generally in presentation of some symptom. For example, for gastroenteritis, the percentage of watch antibiotic here was very high. And you can see for only stomach ache, not even infectious disease, for stomach ache, also they give watch group antibiotics. And from informal medicine vendors, generally when antibiotic is dispensed, it's likely watch group antibiotic instead of access one. And if in healthcare facilities, if nurses were compliant with the new WHO our guidance, we could avert it at least about 70% of all watch antibiotic use in outpatient in healthcare facilities. So this is very huge. Almost 70% could have been averted if they follow the guidance of the WHO book. And what can we say after this finding? So we found a high prevalence of fecal colonization with ESBL E. coli and ESBL Klebsiella pneumoniae in the community. This could be fueling the increase of community onset invasive infection with resistant bacteria we've seen in the neurological hospital and in other hospitals in Burkina Faso. Also, the resistant bacteria was highlighting a multi-drug resistant pattern, reducing also other treatment option. And then we end up saying that this incorrect antibiotic use observed and the poor water sanitation and hygiene condition are likely contributing to the emergence and spread of this resistant bacteria, as suggested by the link with hygiene and seasonal variation. We found that in our first paper. And what was the implication of this regarding antimicrobial stewardship? Who and how intervention should be conducted? For healthcare provider in healthcare facility, their action should be multifaceted, including dedicated education. As you see, the knowledge regarding antibiotics were very vague, and then we need to improve this knowledge. So dedicated education on awareness of EMR. Also improve diagnostic tool. You can see that if a patient comes with an infection diseases other than malaria, then they get lost. They do not know how to do, and then they systematically give antibiotics. So we need to improve diagnostic tool to differentiate bacterial from non-bacterial infection. Also, we need to include patient management algorithm based on the latest WHO recommendation for antibiotic prescription. Also, we also need more regulation from the National Regulation Agency in Burkina Faso. So we cannot allow, for example, watch antibiotic to be dispensed without any prescription first. So we need to more regulation regarding that. For formal pharmacy vendor, we also need to promote regular EMR awareness activities, including dispensing watch antibiotic only following medical prescription. for informal medicine vendors. So as you see, intervention should be targeted to each type of provider. And also at the level, we have to promote regular awareness activities and stress the harm of the misuse of this group, this high risk and potential group, watch antibiotics. For the community, we need to raise health literacy, awareness of risk behavior that leading to emergence and spread of resistant microorganisms in the community. So this leads us to what we have done through the Cabo intervention. So we co-create an intervention with the community, also with healthcare providers, as well as pharmacy vendors and informal drug outlet vendors. So this intervention has been co-created and implemented, and then we measure its effect on antibiotics use, on inappropriate antibiotic use reduction, as well as recent bacteria transmission. So this was conducted in DRC. This is the DRC team, and in Burkina Faso, is the Burkina Faso team and our social science team with people from school. You can see here in the picture, and we based on the latest WHO antibiotic aware book to design the intervention targeting healthcare providers on the right way to dispense antibiotics. What was our findings? So regarding reducing antibiotic use, this was we were very happy with what we found, because watch antibiotic decrease from 20, even nearly from 27 to 17%. So this was we are very happy with this result, and we are continue to try to reduce it more. And then the relative reduction in watch group antibiotic use was comparable between site from Nanoro site and from Nanoro sites and from Kimpese sites. So the relative reduction on watch group was almost similar. And this paper is under review, so is submitted to Lancet, and they give us feedback, and we send back the review, and we are still waiting for the feedback. Also regarding the effects on the AMR transmission, the effect of this AMR on AMR antimicrobial stewardship intervention on resistant bacterial transmission. So we found that we did not have time to explain the intervention very well, because if you take a long time, but so it was an intervention we repeat each 3 months until so it was three round intervention, and then we found that the latest one have we found the effect. We start seeing the effect after the last intervention round. So intervention which targeted the watch aspect as well as antibiotic use aspect in the community, and then but we are not very happy with the result, because reduction rate transmission rate reduction was very, very modest. And then we start reflecting on how to reflect on how to propose new studies to get that to keep done very hugely than what we have seen here. So this intervention help us reduce unnecessary antibiotic prescription, but for the transmission rate, transmission acquisition, this was a very, very, very modest. We found very modest effect. And then for the next step, we have under the alarm study, we have set up a surveillance study to track AMR resistant trend in the community and healthcare facility to guide timely intervention and to contain the spread, and also to guide empirical treatment choice. Also, what we are conducting currently in Nanoro is a source attribution study. You can hear me?
Yes, we can hear you.
Okay, and this is to thank all our collaborators and from the IRSS Nanoro, ITM, the Health Research Center of Kimpese, University of Antwerp, Oxford University, Cambridge University, Institut Pasteur, and Université Catholique de Louvain in Brussels. So thank you very much for your attention, and sorry for this internet issue. and hope you enjoy it and the 4 years. And I will be happy to go through your question in case you may have some. Thank you. So Alipio and Anne, I think the floor is yours.
Yes, I think there are some questions though Q&A, so you can. There's a question for Chastel. Can you read the question and answers Q&A, Daniel?
In the Q&A feature, and as
yes. So he's asking, why did you target only E. coli and Klebsiella to assess the AMR in Burkina Faso in this study?
Yes, in our country, the main isolate from clinical infection was this pathogen. That is why we focus on them. And they were among also the main leading causes of AMR in Western Sub-Saharan African country. That is why we focus on these bacteria.
Yeah.
Is there also?
There is also a question on which methods have been used for characterizing AMR genes.
So we went for whole genome sequencing. We did whole genome sequencing, and then we used online tools to find the recent gene. As you may know, there are a lot of online tools you can use to if you have the sequence, and then to see what is the resistant gene, as well as plasmid. We also check for plasmid for and ST sequence type as well, to see clonality. We check everything, and then the time is not very to present everything, but I think I present what was very important for this session. Otherwise, we also check for STs, we also check for virulence as well, and we have all these data, and we only use online tool to after sequencing that to find all these aspects of the genome.
Okay, thank you. Let me unmute Abdi Fatah. Abdi, you can unmute and ask your question. Okay, as he does that, there's another question.
Can you? Good afternoon, guys.
Oh, yeah.
Afternoon.
Good afternoon.
Thank you for the presentations. It was really very fantastic presentations. Where I think the whole participants get incitement and also some of the technical expertise that we need. Excited, and I think it's helpful. Thank you, Mr. Presenter and the whole team. Otherwise, I have maybe it could be a comments, and at the same time it could be a question. And starting my, we have, before we talk about the drug resistance and those kind of stuff, we need to orient our community, and so we know that and everywhere in Africa we have our community, they are like our society, they are suffering that they don't know which drug they go for, or maybe they use a drug like like a rice or maybe something like this. So before this, I would recommend that we better need to launch awareness on drug use for illegal, and after that maybe it will be helpful for them to decide which one and which one they're gonna use. And otherwise, if I go back to the questions, how can we limit the drug resistance in as a whole? Like, for example, we have in Djibouti, I'm from Djibouti, and I'm a public health, by the way, by professionals, and we have a lot of institutions in here in Djibouti that are suffering or struggling to less or limit the drug use everywhere in order to tackle or mitigate the drug resistance in some conditions, because of we have you can see that people like from cases from the TP, tuberculosis, they have like, for example, we give the drug for to use this, and then they stopped it, and then after that, because of they are unaware that they don't know this is the consequence that they're gonna face when they stop this and drug. So they what they probably do is they just leave it the drug there while they are like in the middle of the drug, and then here is the what is it is that they come back. They come back, and by saying that we have we this and this, now what is the solution? And then it takes too long, so what is the what is the best method we can just kind of issues which has been coming again and again. So thank you very much for I just made it questions, but I'm sorry about that.
Thank you very much. Han, can I? Okay, thank you very much, Farid. Thank you for your comments, and you're welcome. You're welcome. Regarding the point you raised, it's about treatment compliance. If I well understand, for treatment compliance, you can see that mainly on TB. As you said, people may not follow the guidance given by the prescribers, and then they can take the drug, and then once the health condition starts looking good, they stop, and then resistant bacteria start emerge, and then they return, they get back to the hospital and so on. This is also the same for the other drugs, mainly for the other antibiotics. You may prescribe a medicine for a patient and say that, okay, you should take this tablet twice a day for 3 or 4 days, and then you start taking, and then after 2 days, when a health condition start get improving, then it stop. And after that, he came back to hospital, that he may not tell to the medical doctor that I've stopped previously the previous medicine. You see, but for me to come on all these before we prescribe a medicine for a medical doctor or a nurse and so on, the patient needs some information, because the patient may not know the implication of not following the rules. So, but has generally prescribers, they are very busy. They only assess the health condition. They only prescribe, and then giving the prescription and sending them back home without this information of, if you don't take this drug the way I show you, and then you may be probably emerge resistant in your good, and transferring it in your community, and maybe show them some pictures of what you are trying to say, because they may not understand what you are trying to let them know. So if you have maybe some pictures, you may show them as well. Currently, we are trying to conduct also in Nanoro a study about compliance, because we detect some the main prescribed antibiotic, and we are trying to do some video for the patients, and then when they get back home, they can see this video to remember, maybe because they may forget, because as you see in my country, the official language is French, but all people are not speaking French. Most of them speak the local language, you see. So we need to contextualize this kind of thing. Make video, for example, videos in the local language, in French, and in local language to them, and then back home they can from time to time check this video to start to improve the treatment of servants, and this will reduce a bit the recent emergence. Also, prescribers should also get aware of the new recommendation, because what we are seeing in some healthcare facilities, even prescribers are not aware of the new rule regarding prescription. And so this may also not be helpful for in the fight against AMR. So we need to work with these the prescriber, to get them on board, and then show them what should be the rule now regarding antibiotic prescription. And all this will help reduce antibiotic resistance. I don't know if I'll answer all your question. Thank you.
Yes, thank you, almost. Thank you.
Okay. And you are muted. Okay.
Yeah, we have a question from Rachel. She asks, in your study analysis, were there any demographic factors such as age, gender, etc., associated with higher coverage of the resistant bacteria, and who are more likely?
Yeah, okay. Thank you very much for this question. Yes, we have checked. We have checked among age group, but for the age group, we did not find differences on colonization. We did not find difference regarding age group, but we only found a difference regarding the socioeconomic status, as I show in my presentation. The lowest is the socioeconomic status, and the highest is the colonization rate. That means that all the the poorest people, they maybe they are living in a poor water, sanitation, and hygiene condition, and also to afford medicine. As I said, also medicine, medical care are out of pocket paid, and then they may go for consultation directly either to formal pharmacies or informal drug vendor, and then this may be flowing the resistance in the goods. But regarding age, between age, we do not find differences. Muted, and you are muted.
Okay. I see Alipe has answered the question from Emmanuel on collaboration. There's one from Abdullahi. What is the position on animal transmission of resistant gene now? Some scholars have argued that there's no evidence to support this.
Yes, this is right, because what we did in the fecal colonization study, we have checked whether people are closer to animals or not. So for all the household, we also checked whether animal has been keeping at home or outside, and we did not find a difference. We did not find a clear difference on that. But what does this mean? It does not mean that, okay, maybe there is no transfer of resistant pathogen between both. We see that we have a high rate transmission in the community. You see more than 60%. And you see, for even for all those who are watching hand with soap, it's a slight number of population. Maybe this, if you check, it's a higher social economic status member has, and then they have good sanitation, and then less likely to get contaminated. But in the high recent rates of colonization, you may not see a difference between these. That does not mean that there is no resistant sharing. So we need to deepen our research on that and to check, even to sample, and that we are doing that in the alarm study, in the severe study. We are also checking the resistant gene and to resistant gene in the animals as well as in human, and all the household environment. And then we also we also check for relativeness between these different genes. This study is ongoing in Burkina Faso, and I think by the end of this year, we'll be able to share also these results and see how we can tackle this recent in the One Health way. Thank you.
Thank you. Anybody else who has a question before we wrap up the session? Daniel, you can unmute. Danielle.
Thank you. Yes, thank you. I just wanted to ask about two questions in the chat. One was about C. diff, and I'm wondering if you can speak to sort of the level. You talked a little bit about people not understanding really the harms associated with inappropriate antibiotic use. I'm wondering if you know how widespread some of the harms are, such as with C. difficile infection and possible deaths from C. diff. And then there was a second question in the chat from another person asking about the level of support from government regarding AMR. Thank you.
Okay, regarding government support, I will start from the latest one. Regarding government support from AMR, as I show you in my slide regarding the National Action Plan, the problem is finance, because all they used to say all are urgent, and then it's regarding where they should put the money. If you see the malaria burden and other infection disease burden, and then when you start talking about AMR, and then this is something maybe quite new for some of them. And then I think we should work, those working in the AMR topic, we should work to put them on board. And then if they are on board, I think they will support all what we are doing. So I think for me, this is yet to come. Supporting is yet to come. And then from your first question, I did not really understand what you are trying to, your question. I don't know if you can repeat it for me. Or if I understood and then can help clarify. Okay. Your first question, please.
I have to be.
Yeah.
Am I unmuted?
We
Can you hear me? Oh, okay. Sure. I was just asking about your I don't know if it was included in any of your research, but just wondering just even anecdotally what you've noticed about community harms from inappropriate antibiotic use, such as C. difficile, which can be caused by use of third and fourth generation cephalosporins, or other harms that stem from inappropriate antibiotic use. Thank you.
Yes, thank you very much for this question. So this was a point we have checked during our first. You see, if you follow all my presentation, there was a one part to check the extent of the problems, the different problems, and then we developed a targeted informed intervention in the second time. So in the first time, we saw that we have checked community knowledge about AMR and how AMR can be harmful if medicine has not used the way they should. And then we found that this was not known at all for the community. And then they even compare antibiotic to painkillers, that to say that they do not know anything about antibiotic and whether it can be harmful or not. No, they are looking for healthcare, and all medicine are welcome for them. And then when we designed the intervention, even for antibiotic, I don't know if Stefan is here. Stefan is My colleague, social science colleague, is doing his PhD also in the same topic. And even to tell antibiotic with a local name, we should need to reflect that to know how people locally are calling antibiotic, and we do not find a name because medicine is medicine for them. You see, that was a big issue. But with our social science team, we found a way to design this intervention and even present them all antibiotics available from healthcare facilities, from formal pharmacies, and from informal vendors. So we bought all these antibiotics available at these different providers. And when we go to them and we have to present the medicine, the problem, the big issue to do that is that in the informal drug outlet, so antibiotic packaging may be changing. And then if a package change from maybe from 1 year to another, and then they may not know that this is the previous, they said that not to take without prescription. And then this is this call for sustainability. You cannot do such a study and go back home to sleep. No, sustainability might be the key. Thank you. I hope I answered all your questions.
Thank you so much. Great presentation.
Thank you.
Daniel, there is one more question in the Q&A.
Yeah. So
Oh,
as I lost my connection, so I lose all all the question. That the newer was, I can only see the newer one. So if you can read it for me, please. Did you hear me?
Sorry?
I cannot see the question, please. If you can read it for read.
can you hear me?
There is a Nico, I did not catch what you say. There is a Nico where you are.
So Abdullah is asking, Abdullah is asking, what is the possible option for the third world countries? And now by going by one of your findings that poverty was a major cause of bypassing medical prescriptions.
Okay, to optimize prescription, right?
Yeah. They said because you got the findings indicated that people do not use medical consultations or prescriptions because of poverty. They cannot afford the cost of consultations, probably.
Yeah. So we should also reflect on how to put in place a health insurance for African country. So in Burkina Faso currently, we are going through universal health insurance mandatory for everyone. I think this will be very helpful to avoid because out of pocket payment is leading people to self-medication and then without putting some good politic like health insurance. You won't overcome this aspect. Maybe you can show them that what antibiotics should not be done based in pharmacies, for example, formal pharmacies. Maybe you can say that, okay, no which antibiotics should be dispensed without any prescription. And then this should be follow up by local authority, for example, by the district head, for example, they can, okay, all pharmacies working in his district, he can set up a control for that. See if all which antibiotic exist in pharmacy upon medical or nurse prescription. And then this may also be an occasion for feedback to this one. Also for healthcare provider in healthcare facility, we need also to train them, because as you see also, they do not know the problem of AMR is still not well known at the level, and optimizing also antibiotic prescription at the level may follow with including some point of care test at the level, because we don't have laboratory. And then if they get lost after malaria RDT is negative, and then nobody can blame them because they gave an antibiotic because they did not know how to know if it's likely bacterial or not. So we need to help them by supporting, for example, semi-quantitative CRP might be helpful. We did a randomized control trial in Nanoro, and we saw that this also is very helpful on reducing inappropriate prescription. So this can be had in healthcare facility additional to malaria RT. And then for informal vendors, I think they are deep in the community, and we must include community leader when we are trying to fight against AMR overuse at the level. And then I think they understand sometimes, because when nobody go to them and say that, okay, what you are doing is wrong and maybe dangerous for you and for your community, they do not know that. And then after our intervention, we found out that some informal vendors, they decided not to sell watch antibiotic, because they only said painkillers. After some decided to only sell painkillers after we give them the information. They said that, we did not know that, and then nobody told us this information. That is why we thought we are helping people. We did not know that this could be harmful for them. So sometimes knowledge is also the key. Thank you.
Thank you, Daniel. I see we are past our scheduled time, but we've had a chance to engage with the questions and the participants, and I'm sure they can keep the questions coming through email. I'm having a bit of bandwidth issues, so my video is off. But I would like to thank you. It's been a very informative presentation, and we've enjoyed the session. We'll be sharing the recording and the presentation within a week, by early next week. So look out for that in your emails. Thank you so much for joining us this evening. We are likely to have the next webinar, the third webinar, towards the end of the month or early April. Please look out for the invitation and register and join us to continue with this conversation. Thank you, Daniel. Thank you, Alipio, and have a good evening.
You're welcome. It was a real pleasure for me.
And
Thank you very much.
okay.
Bye.